All right, so our first presentation from IFT Team 6. This is a very interesting title here, Devoted Dolphins. All right, let's get started.
Imagine a young child's life transformed by the touch of technology and the power of collaboration, miles away from the nearest hospital. How can a team of healthcare professionals connected only by screens offer hope and healing to a family grappling with pediatric asthma in the most remote of settings? Hi, my name is Alex, and I had the amazing opportunity to work with many great individuals pursuing a variety of careers in healthcare. We were tasked with collaborating on a pediatric asthma management simulated case study. So in this case study, the Devoted Dolphins worked together as a group of 10 students to plan a collaborative telehealth appointment series where Charlotte, a 6-year-old with asthma, recently moved to a rural area with her parents. Pediatric asthma poses significant management challenges, especially in those remote and rural areas with limited access to specialized care. Here we kind of explain Charlotte's background. She is a 6-year-old diagnosed with allergen-induced asthma at the age of 4 with a persistent cough, easily winded and fatigued. Her parents, Simone and Daniel, were interviewed within these 2 series, which we'll talk about the methods in a little bit, with an active lifestyle that is limited now due to this asthma. Frequent visits to urgent care and some medications, such as her control medications of Advair, Monolust, and Claritin and Benadryl. She also has rescue medications such as her albuterol inhaler, prednisone, and other steroids. And the family's concerns are this quality of care, and this was really discussed throughout the interviews and the telehealth appointment that we had with the parents. So our team featured a variety of health profession students from the University of New England and Rosalind Franklin University, which included osteopathic medicine, public health and nutrition, occupational therapy, physical therapy, dental medicine, podiatry, and a community health outreach worker. We would like to especially thank Dr. Prast, Anthony, and Josh for helping us out with these telehealth appointments. So specifically talking about these 2 predetermined and simulated case studies, the specific methods and the specific setup for this telehealth appointment was a pre-debrief before each telehealth appointment where we discussed team roles and responsibilities, collaborating on setting a plan of action, goals of care, and how to utilize telehealth for SOTO's care, or for the SOTOs, and prepare a general guide for questions. Our telehealth appointments were divided up into 2, where the first appointment was only with Mrs. Soto, so this is Charlotte's mom, where we wanted to build rapport, discuss the chief complaints, review any medical history, special healthcare evaluations, explore environmental components. We would then go through a debrief and a handoff where between each session we discussed the outcome of the interactions and the telehealth appointment. And then our second telehealth appointment included both parents. We wanted to update Charlotte's condition and go through any treatment modalities that we deemed appropriate. So appointment 1, building rapport, we wanted to foster a trusting relationship between Mrs. Soto and the healthcare team. We wanted to understand Charlotte's primary concerns and symptoms from Mrs. Soto and Mrs. Soto herself, gather more detail about her medical history and discuss the medication she's taking. We wanted to go through these different healthcare evaluations, specifically environmental components, to explore the potential for this new rural place they moved into. Some takeaways from the first appointment, we understood that Ms. Soto cares really deeply for Charlotte and had many concerns over how asthma affected her livelihood and her school. She was getting a lot of comments from the school about, Charlotte's attitude. So we wanted to tailor a treatment plan that was unique to the family as well as follow up on any progression. We also took away that knowledge and access to different services would greatly improve Charlotte's condition. So we wanted to research and provide the family with resources for their situation, including rural access, or problem to the rural access and the asthma and oral health management. Telehealth visits are really essential for access to care in such rural areas and these places. And they present really unique challenges, which is like question types, virtual vitals and labs, and trying to get tours of the house. So we wanted to structure questions for this next interview and be courteous of time with focus on being an empathetic, patient-centered provider. So appointment 2, we wanted to address previous questions that we did not get to, review and answer of those outstanding questions, updates on Charlotte's conditions as there was some observations and progresses since the last visit, and ease any parental anxiety by offering reassurance. So some takeaways of the second appointment, it really reinforced the notion that empathy is vital to connect with patients and families to be open about their situation. Having any family member, spouse, or another member person present during a telehealth visit can really alter how the healthcare providers discuss and formulate treatment recommendations. Patient goals and factors also influence how willing the patients or the clients are to achieve these goals, and access to social workers would have really helped in our situation and help improve the social burden both on the family and Charlotte through the knowledge and access to these services. So just wanted to cover through the interprofessional collaboration core principles and best practices, which we try to utilize during this time and going through each telehealth appointment. strengths and limitations of collaborative telehealth, we really saw this improved access to specialized care that the SOTOs had. There was enhanced communication and coordination, which was amazing to see real-time and multidisciplinary team meetings between the providers. And we also saw an increase in patient and family engagement, especially in that second appointment with Mr. and Mrs. Soto. However, there were some technology barriers. The internet wasn't super reliable on summons, especially Mrs. Soto's device. We had a really hard time with the limited exam, and we also saw that the patient had reduced connection between us. We would have loved to have that one-on-one. Bridging gaps for these rural populations and where they're at, we saw that accessibility challenges were huge. Knowledge and disparities, fragmented care, difficulty in coordinating care among all these providers were hard. We try to, have these telehealth solutions, but strengths and limitations were very evident. So we learned that effective collaboration with other health and social professions, how to utilize telehealth for our own work, how to interact, communicate effectively with patients, and how to utilize motivational interviewing, discuss changes or learn from our patient. What we would have done differently and will do differently next time is not pre-forming our questions, rather listening to the patient and engaging in those conversations in a fluid environment. Understanding the constraints with working with many professions and follow-ups after these 2 appointments are going to be essential. We would like to thank the CAIEP and the University of New England for the effort of all students, faculty from both UNE and Rosalind Franklin.
All right, all done. So our team members from this presentation actually here. Raise your hand. All right. All right, so feel free. We're open up for questions. Anyone have questions for the team? So I'll start one. So in your reflection, you mentioned that in the future, what you would do differently, you would actually use a less of pre-structured questions, but actually listen to the patient. So what you actually learned from that experience, what kind of issues or things that come up through the conversation which you did not think about it?
Yeah, there was multiple topics that we had chatted about with the parents, and it felt that we wanted to go one direction, but the parents were thinking another direction of what they wanted to talk about, and not necessarily knowing what direction that might be. So just being a little bit more fluid with this is the direction we intentionally had, but we're going to take it into this direction, which would have been super helpful for some of the cases.
Mm-hmm. So that would actually reflect the patient-centered, right?
Yes.
What you want to do, you want to really fit the patient's needs as well.
Yeah, and we tried our best with that. We had a line of where we wanted to go with it, and however, there were some times when we definitely had the questions, and we just we were like, oh, do we add it in here, or we try to fit it in this, and you just kind of have to let that conversation flow naturally for patient-centered care.
Mm-hmm. This is another project from IFD. Another interesting title here: Unleashing Positive Empowerment. It's from Team 3. Let's go ahead and listen.
Hello, we did pediatric asthma simulation case in interprofessional care. This was our interprofessional team. We had Belle Bogle, social work, and Mary Obb as our instructors. I'm Essie Love with the College of Dental Medicine.
I'm Darby Melia with the College of Osteopathic Medicine.
My name is Hannah Griffin, and I'm also with Osteopathic Medicine.
And I'm Sarah Ray, and I'm with the School of Pharmacy.
So we had our patient, Charlotte Soto. She was age 6, and she was diagnosed with allergen-induced asthma at age 4. These were some of her symptoms, and she was on a lot of medications, which was the family's primary concern. For us to approach this, we had to ask the question of what is the best way to come together and provide her with the best care. So we determined our values and our healthcare ethics. And by following these throughout this experiment, we were able to have improved patient outcomes.
At the beginning of the interprofessional team immersion, each individual came prepared with our ideas about what our roles may be in a case of pediatric asthma. We shared our goals of our profession, and we came together to integrate these into a patient-centered integrated care approach. And we found that we shifted dynamically as a team to address each new concern, and we reevaluated who may best address the concern at hand as time went on.
Another major takeaway we had was the importance of communication, both interprofessionally and with the family and the patient. We found interprofessionally that it was crucial to be active listeners to others and be flexible to our own priorities in order to optimize patient care. We also wanted to make sure when talking to the family that they felt heard and the patient's concerns were addressed. And we also wanted to speak respectfully and in a language the patient and their family can understand without using too much medical jargon.
And lastly, 2 overall points that were crucial to our team's success were defining roles and responsibilities before indulging in any of the work on the Charlie Soto case, and making sure to maintain effective communication to avoid any duplication of work amongst our different specialties. And just one con that we found that was a challenge for us was having too many cooks in the kitchen during some of our work within the IPI, to have too many hands on deck all at once. But focusing on the above key takeaways allowed us to stray away from this challenge we faced.
Great reflections. Anyone has questions? So I think this is the same case that presented by the previous team. And I put out a couple questions in the chat. Feel free to answer in the chat or just speak up. Go ahead, Emily.
Can I ask a question to the team?
Yeah, sure.
Sorry. You said one of the cons was having too many cooks in the kitchen. Do you feel like this was because there was so much scope overlap, or was it due to just like inter-team communication about who was doing what? Like maybe digging into some of the root causes from a teamwork analysis. What are your thoughts as a team?
I think one of the things that we discussed was when we were actually meeting with the family, some of that was shown through, like, we all were like, okay, we shouldn't all go in there. We shouldn't all overwhelm them with our questions. We shouldn't all like just go at them with all this stuff. And so that was kind of like, I know an example of too many cooks in the kitchen is we were like, okay, who should go represent us? Because if we all go in with our different professions, that's very overwhelming to the family. So I know that was one example, and I don't know if anybody else wants to add anything.
I'll say I agree with everything you said, Sarah, for sure. Like, it was hard to determine because the family had a lot of concerns. And every time we talked to them, they came up with something new, and we were like, oh, like nutrition would be great to talk to them about that. Or like, but again, we didn't want to overwhelm them. So it was kind of hard to make sure in the limited time frame that we had that all voices were heard appropriately. And then also that we all learned different approaches to patient-centered care in the different professions. And so we were all like wanting to utilize what we had learned. It was hard to do that in the time frame we had.
Yeah, Essie really touched on this, but I think one of the biggest problems we had with too many cooks in the kitchen is just not having enough time. I know every specialty ideally would have so much more time, and these sessions were so short. We didn't have time to have everyone get to express all that they wanted to speak to the patient about.
So do you see any solutions for this for your
I can take
too many
this one.
cooks?
Yeah, I think what really helped us with that was really meeting beforehand and discussing our roles and responsibilities as a profession and as someone that felt comfortable with that role. So it wasn't necessarily just like because a lot of roles overlapped, like you said, Emily. So I think that a lot of it was kind of figuring out where you felt most confident and comfortable and kind of having that open discussion and meeting beforehand.
And also get back to what the first team actually mentioned, listen to the patient more. So maybe we'll focus what you want to do with the patient instead of what you want to do for the patient.
I think that sometimes the most challenging thing is when everybody on the team starts with their individual lenses, and then you put all those lenses on top of each other, you realize how many things you really could try to tackle. And then you're like, oh my gosh, but where do I start? And I think, Dr. Sao has a great point. It's like you start where the patient needs help. And it's like, what do they come to you for? And how do you focus on prioritizing things? And I think as you progress as students, you learn the skill of prioritization and then the skill of listening. And those are like the two most important things you can take away. And then as a team, you just get better. I like to talk about how like the difference between a starting team is like you look like a bunch of like level 1 soccer players where they're just all the kids are running around chasing the soccer ball and there's just a clump of people. And then eventually as you get more skilled as a team, you actually can start to pass to each other and or anticipate where the ball is going to be when your teammate doesn't give you a look, but they're going to pass in the future. And that's a really great team. You guys are on your way. That's awesome.
All right, we're moving towards the third presentation. I think this is from one of the FIT team. All right, so this is from our FIT program team 8. The topic is navigating transportation for houseless patients, right?
Hello and welcome to Reducing Barriers for Houseless Patients, Enola. Enola is a social and outgoing individual who enjoys spending time with her friends, who always lend a hand or a couch to surf when they can. She was recently diagnosed with stage 2 chronic lymphocytic leukemia. She's currently being treated in Portland, Maine. She was previously labeled as non-compliant due to her health and access barriers, which include houselessness, communication devices, transportation, and uninsured from health insurance. She is a Cherokee Native American woman who was displaced when moved away from her tribal community at a young age. Here we have a framework of Enola's life. As I mentioned, she has poorly managed stage 2 chronic lymphocytic leukemia. On the individual level, she is unemployed. She's eligible for Medicaid and Maine Care, but she has difficulty with the paperwork. She also has poor nutrition and she's underweight. In her family and friends, she has no living family, and she relies upon her friends for couch surfing and social support. For her broader community, she lives in Poland, which is a small rural town with poor walkability about 30 miles from Portland. And finally, in her environment, she has no access to a car, no cell phone plan, so she relies on Wi-Fi for communication, and she has no reliable transportation to treatment.
As a team, we've come up with various interventions that may help Enola. To begin, we'd like to get her a case manager that will assist in the enrollment in Maine Care, allowing her to access many of our intended interventions. With the help of her case manager, we'd like to move her treatment from Portland to Lewiston, Maine, with the Central Maine Cancer Institute, which is only 11 miles from Poland, than the 31 miles before. Enrollment with Lifeline will give Enola access to a phone plan, which she can use to schedule transportation to and from her appointments. In regards to nutrition, the case manager can assist in the enrollment of SNAP and use Uber Health for delivery of food. Through the Cancer Institute, they can assign her a nutritionist and give her access to a cafeteria and a kitchen. Similarly, we can help her apply for short-term housing with the Arbor House associated with the Cancer Institute. However, we'd like to find her long-term housing in Poland through the use of resources like Avesta Housing. Lastly, we plan to not only foster health, but social and mental support for Enola. Through places like the Dempsey Center, she will have chances to build community with others. We also want to help Enola foster a strong connection with the Indigenous community through Tribal Health Liaison. Similarly, we'd like to help her gain her sense of self and cultural identity by acquiring a wig through the American Cancer Society. With this multifaceted approach, we hope to address Enola's needs.
All right, so we're gradually moving from individual patients and then to look outside the patient and what we can do to help with the patient. Feel free with any questions, and also feel free to turn on your camera. We would love to see your face. Any questions? I can start with one. This is a kind of combined with the first case we heard. This is about the internet issue. So we're a rural state, and then not everywhere has the same quality of internet connections, and it is important for every patient. Even you give the patient the cell phone, and a lot of time it has to require Wi-Fi. What would you guys do to help us with this problem?
Sorry, to make sure that I understand the question. Are you asking like how would we kind of circumvent the issue of rural places not having reliable Wi-Fi?
That could be one of the solutions, and the other thing as well. Anything you can think of.
For how to do that? I'm not sure what the question is.
Well, maybe give us some suggestions. You could circumvent that.
Oh, okay, gotcha.
Hi, Dr. Sao. I can jump in here. I'm not too familiar on internet in the rural areas, but I imagine by researching each individual county, we could figure out which area or which plan has the best access to Wi-Fi, and then hopefully via something with main care or with social work, trying to get those prices reduced for whichever company has the best Wi-Fi in that state. In terms of getting additional Wi-Fi, I think that would take a lot of advocacy in terms of outside health, outside of social work, but that would be our first step, I believe.
That's perfect. That's exactly where I want to going for. So besides really just, taking care of the patient in front of you, seeing the bigger pictures is also important. You could have treated 100 patients who also, who has all variety of problems, but all have the internet issues and you cannot solve. So advocacy is your responsibility as well. So looking outside, you might not think this is a part of the healthcare, but it is with the telehealth usage and with a lot of telemedicine, and you prescribe medicine, you interview patients, and you all need internet. So everything is related, and if the population is not healthy, individual cannot be healthy. So this is exactly where we're at. I want to go into advocacy. All right, so the last one is also part of our FIT program. This is really near to my heart. It's a topic about a chronic pain, a case of a chronic low back pain, interprofessional approach. Right, let's get started.
Hi, my name is Hunter Scott, and I will be representing Group 5, and we will take you through a case of chronic low back pain with an interprofessional approach. We'll first discuss our patient, the narrative, our model, and interventions, and the healthcare team involved. First, Mr. Plant is a 76-year-old male shipbuilder from Bath, Maine, with a 30-year history of chronic low back pain following an incident at work that led to spinal fusion surgery. His pain is currently a 6 out of 10, which was previously managed with opioids, but he has since transitioned to over-the-counter pain medication. He's presenting to his primary clinic with a change in his pain pattern, plus anxiety, depression, and he's wondering how he can improve his quality of life. We'll examine this patient's individual, interpersonal, community, environmental, and policy factors that affect his health. So first, from an individual level, his occupation, past medical history, and plus comorbid conditions and lifestyle factors all impact his health. From an interpersonal perspective, his wife has become desensitized to his condition over the years. He's also estranged from his children and siblings, and he has lost touch with some of his friends through work, and has had a difficult time maintaining connections. From a community level, he lives at a greater distance from his care providers. The pain has also limited the interactions he can have with support groups and religious services he used to attend. His town is a rural coastal community in Maine where he's able to travel by car, but the pain can limit this. And he does receive some workers' compensation, but he's wondering if he is entitled to additional coverage. This is a summary of what we just covered. And for interventions, we will first consider physical therapy to address some of the patient's pain and sedentary lifestyle, plus comorbid conditions. This can all help with that. Riverside Physical Therapy is available in Bath, Maine, but it should be noted that this may require prior authorization by his insurance. Additionally, he can acquire main care coverage as a disabled adult, which could provide some assistance with additional costs, and also potentially provide a case manager that could help manage his complex condition. And lastly, behavioral health services could be sought out for both he and his wife due to a positive PHQ-9. And all of these healthcare providers can be found locally within the town of Bath to provide support. Thank you.
All right, we are open up for questions. Anyone want to ask your questions? All right, so I want to ask the team member can raise your hand so we all know who you are. What does your patient actually want at this point?
I can answer this one for the team. I think that we sort of envisioned that he came into his appointment just as sort of routine follow-up for his pain. But during the visit and a little bit beforehand, we found out that he had things that were happening outside of his life, namely his anxiety and depression, that were sort of exacerbating his pain, and making it hard for him to do things that would help his pain, like his fear of movement, because of his pain, was really impacting his like ability to heal and remain positive. So I think that identifying the anxiety and depression was really key towards like making a new plan that wasn't just a continuation from the old of managing your pain, and doing the same thing at the visit. I think there's a question from Mr. Sheldon.
Yeah, I'm Mike. I work in the provost office. You may have just answered it because very appreciative of acknowledging all the different team members who might contribute to, this particular client's, resolution of their issue, or at least, helping to mitigate what they've been dealing with. But if you had to sequence them, prioritize, and it sounds like based on your answer, that maybe addressing the anxiety piece that you identified would be something that, okay, we can't do everything at once, but this would be something. In fact, we definitely want to do that before, let's say referring to physical therapy, where they're more likely to, want to initiate, movement therapy, that type of stuff. So I'm just kind of curious if, in your minds, like, okay, priority wise, we'd want to start here and then kind of move through in terms of the plan that you were working on.
Yeah, definitely. I think during the visit, identifying what the patient identifies as his first priority, or like what matters most to him in his treatment plan, is the best part of moving forward in his care. Hunter's laughing because we both do the GEM project, and that's the biggest part of that, is identifying what matters most for your older adult patients. So I think if he isn't ready to start PT, then doing a PT recommendation at that visit isn't really going to help him. But maybe through his support groups, he can identify like, okay, I feel ready to start PT now. And that's what he can work on down the road, or work towards now. Hopefully that answers.
Yeah, thank you.
Yep. Yes.
All right. So I kind of want to get back to the core of the program, the public health component of this. And then chronic pain is a really significant public health issue. So through your sort of workings, the project, what do you think is the number one priority you should advocate for?
I think, like we said, like our patient lives in like a more rural area of Maine, and I think one big thing that is a barrier to him is like access to resources nearby him. So maybe just like trying to work with him and work with other companies like transportation, or like other ways that he could get telehealth appointments or stuff like that, so he could have like access to all these resources, like maybe closer to home.
Think about it, advocacy also, not just, one or two other partners. You could work with the state, could work with the universities, it could work with the companies, healthcare systems. So that's all become your partner to work on this. So another related question. So we have started this pain registry, and so far the participants are actually have a good housing, good stable job. On that part, they're not lacking or has a disadvantage. But whoops. But their issue is a lot of was frustration with the providers. They don't understand my pain. They don't have anything else to offer to me. Just quickly, I know we're ending. Anybody have a response to that?
I think you actually kind of touched on it earlier when you were talking about advocacy. One of the things that providers, I think, can do and are doing probably a really good job at, is getting creative with solutions for patients. It starts with listening to what their primary concerns are, but it also is sort of like thinking outside of the box of medications, or like stretching or going to PT. It's sort of listening to what your patient's barriers are and their concerns, and thinking with them, not just for them, about what you can do to help them like accomplish their goal of lessening their pain or getting rid of. It's not always about, eliminating the problem entirely. It's about making their life, their quality of life feel like it's higher.
Exactly. All right, perfect. And thank you all for coming and the great work, and hopefully to see you guys in this become the leader in interprofessional practice in the future.